Welcome back to another video of medication overdose in the ICU. Beta blocker overdose clinical presentation is these patients will come in with symptomatic bradycardia and hypotension, elicit collateral from either the family member or patient, and you'll be able to discern whether or not this is something more ominous or if it's a beta blocker overdose. The treatment for these patients is glucagon. I made a little schematic on the side there, and you can see the cellular pathways of why glucagon is advantageous in beta blocker overdose. It's also used in calcium channel blocker overdose. However, it's not as efficacious due to the signaling pathway, as you can see on the schematic to the right. Benzodiazepine overdose is these patients are lethargic and they primarily have respiratory depression. You can even have a very wide range, even hallucinations, agitation, confusion, but mostly you see lethargy, respiratory depression. The treatment is overall supportive, protect the airway. However, you can use something called flumazenil, which is the antidote. We often do not use this in practice because of the varying half-life of benzos and flumazenil. They're different, and it can precipitate withdrawal and seizures. So in this instance, I would primarily use supportive therapy. When you have someone that comes in with nausea, vomiting, malaise, they're very non-specific symptoms for acetaminophen overdose. Because the hepatotoxicity peaks around day 3 and 5, you could also have patients come in with hepatic encephalopathy, oliguria, renal failure, lactic acidosis. If you're able to obtain the time of ingestion, either through family member, collateral, or patient, you can use a nomogram to help you discern whether or not the patient will have hepatotoxicity. So this is a very basic schematic I made. The nomograms that you'll use are usually much more detailed, but the basis is the same. You're gonna take the acetaminophen overdose. You're going to look at this graph. It's going to have hours after ingestion on the x-axis, and the y-axis is going to be the acetaminophen plasma concentration of micrograms per liter. And it'll tell you if the patient is at risk for hepatotoxicity. So you stay below this threshold, particular threshold of the red line. That's a low risk. If you're above it, it's a high risk. The max dose of daily acetaminophen is 3.25 grams daily. So that'll help you in your treatment modalities. The main thing with the nomogram is you have to know when the acetaminophen was ingested, and that'll give you the basis of whether or not they're low risk or high risk for hepatotoxicity. For treatment, these patients we use N-acetylcysteine, and how that works is basically there's a cysteine residue in the N-acetylcysteine. It has a sulfohydryl group, and it basically reduces the toxic metabolite in acetaminophen. There's literature that supports therapeutic benefit with activated charcoal as early as 4 hours and as late as 16 hours after the known ingestion. For opioid overdose, these people come in with pinpoint pupils, somnolence, and decreased respiration. A normal pupil is 3 to 4 millimeters. However, these patients with pinpoints will usually have less than 2 millimeters. The treatment is naloxone. It's an opioid antagonist. It primarily affects the mu receptor, which is responsible for respiratory depression, analgesia, euphoria that you experience when opioid use. It's less effective, though, on the delta and kappa receptors. So the treatment for these guys is naloxone. Rounding out the list of medication overdoses in the ICU setting is salicylate overdose. This is probably my favorite because of the acid-base implication and physiology. It makes logical sense when you think about how the primary presentation is respiratory alkalosis and metabolic acidosis. You could see some nausea, vomiting, tinnitus, agitation as well. So what happens is the salicylates act to uncouple oxidative phosphorylation, which results in an increased anaerobic production of lactic acid, which leads to the metabolic acidosis. Very straightforward. I added the mud piles here just to reinforce that mnemonic of methanol, uremia, diabetic ketoacidosis, alcohol ketoacidosis, starvation acidosis, propylene glycol, isoniazid, inborn errors of metabolism, lactic acidosis, and ethylene glycol. And then the S, of course, stands for salicylates. So the treatment, what we're going to do is alkalinization of the urine. And so, again, physiologically, it makes sense. If you increase the urine pH, it will cause the salicylic acid to disassociate and basically get stuck on the renal tubules, allowing the body to flush out through the urine the salicylic acid. Sometimes our treatments, these bicarb drips, don't always work. And so one of the indications for hemodialysis is actually if you're undergoing alkalinization of the urine and it's not working. Some other reasons we'd use hemodialysis would be when the serum salicylate level in the body reaches 40, the toxidrome symptoms and clinical manifestation is worsening despite treatment, and that's also an indication would be if they have ARDS or worsening clinical picture. So that's pretty much it. We went over beta blocker, benzodiazepine, acetaminophen, opiate, and salicylate overdose. And that concludes this video. Happy studying!